I have kept all classical slides so that you can able to easily pick it up. Most of the slides I have done a cut and paste from Robbins' book. So once you study the Robbins theory part, so you will study the practical also, same slides, okay? Most of the slides. Few slides I have taken from my PowerPoint, from Google, like that. So today we will discuss about last practical session. We had a discussion about urine analysis. So in urine analysis, mostly I'll keep few slides. Then last session we discussed about kidney and lower urinary tract. So in that I'll keep almost 5. Each and every session I'll keep 5 slides. On today's session is about male genital tract and female genital. In male genital 5 slides and female genital 5 slides. Okay, I'll try to keep the maximum number of slides. Get in. What's time now? Is it time? 12:10. Okay, fine. So coming to this male genital system, we'll see about penis and the tumors of the testis. Okay, coming to the penis, it's well known here. You can see this is the shaft and the glans penis. Okay, this is an amputated penis. Penectomy has done. Okay, this is the shaft and this is the glans penis. In the glans penis, you can see this is the prepuce, which is red and inflamed, as well as you can see in the glans penis some kind of an cauliflower growth, cauliflower shape, kind of a proliferative growth. Okay, if you do the same thing, do an section. Any doubt? Any doubt, Tariq? You have a doubt? No. Okay, so if you do a small bit of tissue, if you do a section, and if you do a staining, this is an HND staining. What you are seeing is the epithelium. The lining epithelium of the penis is the skin, squamous epithelium. What you are seeing in the top is the squamous epithelium, and bottom one, these are all the tumor cells. These are all the tumor cells. See, this is the epithelium, this is the tumor cells, these are all the tumor cells, which has been from the top, it is infiltrating down. Okay, this is an infiltrative squamous cell carcinoma of penis. Okay, and moreover you are seeing here keratinization. Most of the times in squamous cell carcinoma there will be keratinization. This is a keratinizing squamous cell carcinoma, or else you can mention at infiltrative or else invasive. You'll be having different terminologies if you read in the book. Infiltrative and invasive is the one and the same. It's an invasive squamous cell carcinoma penis. Type is keratinizing type. Okay, that's why I mentioned as a simple form, keratinizing squamous cell carcinoma. But you have better to add an invasive. Okay. Invasive squamous cell carcinoma. Penis. Okay, better to have like this. This is the keratinization what you are seeing it here. Next slide. Again you are seeing as an infiltrative and ulcerative growth in the penis. Okay, in the glans penis. This one also you can see here, this is also a growth over here. This also you can see a growth which has been having a depression, and same thing if you do a staining, HND staining, you can able to see. This is a hyper view, this is a scanner view, that's why you can able to see the epithelium. This is a hyper view. For your better understanding, I have kept this slide so that these are all the malignant squamous epithelial cells. This is the malignant squamous epithelial cells. Okay, here almost it's going into stage of an moderately differentiated to poorly differentiated. In well differentiated only you will see well defined squamous cells with the keratin pearl. Coming to this poorly differentiated, you will see a single cell with keratinization. This is not poorly differentiated, it is transforming into that stage, but it's moderately differentiated here. You can able to differentiate. This is the squamous cells. These are all the squamous cells. Okay, I'll keep you both these pictures, and I'll ask you a 50 years male having an ulceral proliferative growth in the glans penis. The same patient microscopic features has been kept for you for your what's your interpretation? I'll give you the 4 options: squamous cell carcinoma penis, or else adenocarcinoma. Here there is no adenocarcinoma, okay? Squamous cell carcinoma penis, adenocarcinoma, or else a mucinous, or else serous, something like that, okay? So you can able to pick it up. Next is, we'll go for the tumors. Yes? Full slide I'll keep you.
No, full screenshot.
Yes. Oh, okay, okay. Okay. So you can able to see here, this is the glans penis with the growth here, ulceroproliferative infiltrative type. This is the microscopic picture showing this tumor cells. This is a more minimal keratinization. This is a keratinization here. Okay. Shall I go for the next slide? Okay. Next we will go for the tumors. Tumors, you know, many testicular tumors has been completed, right? Okay. Can you tell me some tumors apart from seminoma?
Stromal cord.
Sex cord, stromal tumor.
Germ cell.
Germ cell tumors, sex cord stromal tumors. In germ cell tumors, you have seminoma, yolk sac tumor.
Seminoma.
Yes. The most important testicular tumor in germ cell tumor is seminoma. It occurs in the age of almost 30 to 50 years. Okay. So the classical pattern of this seminoma is, it is homogeneous. If you do this, the testis, the spermatic cord, if you do on a cut section, you can able to identify this homogeneous pattern, in the sense there won't be any kind of other features like necrosis, hemorrhage, cyst, any kind of growth, proliferative growth. Okay, only a growth will be there. It will be homogeneous. Homogeneous in the sense it will be uniform. Okay, what you are seeing, this is an uniform pattern of growth, and in between the uniform pattern of growth you are seeing a thin septa here. Okay, this is the thin septa, this is a thin septa, this is a thin septa. This is a well circumscribed. This is a well circumscribed in the sense you can able to identify the border margin. For that we will say well circumscribed. This is a well circumscribed, pale, fleshy, homogeneous in the sense uniform, separated by thin septa. This is the thin septa here. Okay, it's a thin septa. If I keep you only this picture, you can able to pick it up seminoma. Along with this, this is very classical. See, this microscopic picture shows you a large cells. This is the nucleus. This is the cytoplasm. This is whole thing is a nucleus. Here, this is the nucleus, and the pink one is the here. This is the cytoplasm. Inside, what you are seeing is a nucleoli. You will see a large cell with a distinct cell border, and in the center you will see nucleoli. Here you can able to see, this is the nucleoli, nucleus, this is a cytoplasm. Further here, this is the nucleus. Inside, what you are seeing is a pointed one, nucleoli, and this is the border. Okay, here also you can able to identify here. This is here. This is the nucleol here. This is the nucleoli, nucleus. Hello. Yes. 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 Dr. Salma. Hi. Okay. So, yes. Next week Sunday. Next week Sunday, but the exam will start for them, right? Exam will be there for them.
No, they have the exam at 1. They changed the exam will be 1 p.m.
Okay.
After the exam, right away, something like 11 to 3.
Okay. Next week Sunday 11 a.m. Okay. Next week Sunday in the sense January 1st. Okay. Fine. I am ready. Yeah. Yes.
I have a question.
Yes.
You are the one who will do the practical optic.
Yes.
How many
For the pathology per session, I will put 5 slides. So totally we have a 3 practical session. Totally I will be, from my side it will be 15 slides. 15 slides I will be sending to coordinator, and he will be having an access over the slides, and he will select the slides.
Okay, thank you very much.
Yeah, okay. Yeah, welcome. Okay. So now here, this is a homogeneous pattern. What you are seeing, this is a testicular tumor with a fine septa. The same thing, if you see it here, this is the nucleoli here. This is the nucleoli in the center, nucleus, cell border. Cell border is very classical here. This is the cell border, whole thing is a nucleus. In the center, what you are seeing, nucleoli. Again, it's a nucleoli here. This is the some few lymphocytic cell. This is the sparse lymphocytic. This is the classical pattern of an seminoma. Okay. Next is about, we are seeing about testicular tumors. Previous slide I will show you later. Next we are going for embryonal carcinoma. The difference between these two is, it is in the embryonic stage, and moreover the tumor, it will be hemorrhagic. They are no hemorrhagic, and more here it is in the beginning stage. As such, the cells will look like beginning stage. Okay, we'll call it as sheets of undifferentiated cells and primitive gland-like structures. This is the gland-like structure. So the gland-like structures. This is the gland-like structures. All the cells, it is you feel like it's going to get mature. Okay, but all the cells are large and hyperchromatic. This is the large and hyperchromatic. If you see in your laptop, it will be much clearer than this PowerPoint. Okay. Next is about yolk sac tumor. Only for this yolk sac tumor, I didn't keep the gross picture, but I'll give the history of when the yolk sac tumor will occur. What's the age group? Only this is having only little difference. Yolk sac tumor is age group is children in the age group of approximately age range.
3 years.
Very good. In the mid 3 to 5 years. Okay, 3 years. I'll give the history of 3 years or 3 or 4 years, 5 years. Easily you can able to pick it up, this yolk sac tumor. And one more feature of this yolk sac tumor is, this is resembling like, how it is resembling like? Tariq, can you pick it up?
What?
How it is resembling like? This one.
Glomeruli.
Very good, glomer-like. It is resembling same like glomer-like. Okay. So that's, I will describe you about this. Demonstrating areas of loosely textured microcystic tissue. This is all the cyst. This is a cyst. In this cyst, there is a lining here. And in the lining inside the lumen, you are seeing a papillary structure. Okay. This is known as a Schiller dual bodies. A cyst with a lining. In the cyst, there will be a papillary projection inside. In the papillary projection inside, you will see a blood vessel. This is a blood vessel. This is a blood vessel. This is a papillary projection. This is the wall. Okay. This is a feature of a Schiller dual body. Who has find out this? Here they have kept the same name. For this, it is an younger age group. Apart from that, all the age groups are middle and adult. Next is about BPH. This is very classical. You can see the nodular pattern. This due to the enlargement of the glands, it has been compressing the urethra. This is the prostatic adenocarcinoma. What you are seeing here. This is the normal feature, and this part here. This is a mass-like lesion, light yellowish color. Okay, this is not clear here in this display. Same thing here. I'm going for the microscopy. This is the gland structure. This is the stroma. As we were discussing yesterday, proliferation of glandular structures and the stroma will be the feature of an BPH, benign prostatic hyperplasia. Hyperplasia indicates increased in number of the glands and in the stroma. Okay, what you are saying, this is the stroma here, and this is the glands. This one they say that it is a compression of the urethra. Left one is they say that demonstrate well demarcated nodule at the right end, and with a portion of urethra seen on the left. You don't need to describe about this. Hyperview of this one single gland shows you 2 layers of epithelium. One is a basal layer, another one is a columnar layer. That is the feature of an prostate. Can you tell me the other examples of 2 layers? First, one I said you here, this is the basal layer. Classical here is basal layer, this one, flattened epithelium. Basal layer, this is a columnar layer.
Papillary thyroid carcinoma.
Papillary thyroid carcinoma. Okay, no. See, see, the clue is prostate, it secretes some secretions, right? What is the secretions?
Prostatic fluid.
What is that fluid? Resoproteinaceous fluid. What is that fluid? It is an corpora amylaceae, right? Or some glands they secrete, some ducts say they secrete secretions. Those glands are lined by double-layered epithelium. For example, what are secretions? Like salivary gland, okay, breast tissue, okay. These are all the helpful in ejecting the secretions from the lumen from the epithelium to the lumen. That's why they are helpful in the double-layered epithelium. You will be discussing the same topic in breast. Maybe Dr. Mavi he'll be taking about the breast, right?
This is papillary thyroid carcinoma.
You will discuss about you.
Okay. Keeping it all around.
No, I'll tell you about this papillary. It's not the one. Okay. No. I have done my thesis in papillary thyroid carcinoma. See about this. This is the nodule. This hyperview. This is the papillary. This is the glands hyperview. Okay, it's clear. This one.
Yes.
Next is about same thing only. For you, see, this is, if it's not clear, I have kept few more pictures for you. This is the gland. This is the gland. This is the stroma. You can see the gland structures lined by tall columnar epithelium. This is the stromal features. Further hyperview. This is the. I said you there will be an lumen projection inside. This is the projection inside, right? This is the one, lumen projection. Glands appear closely packed. This is one gland, this is the other gland. This is one gland, this is the other gland. This is closely packed in benign hyperplasticity because of the increased number of glands. This is the stroma. Okay, this I kept it minimized. If you see in the laptop, it's clear. Next, we will go for adenocarcinoma. Adenocarcinoma, till now we discussed about BPH. BPH, you can see this double layered epithelium, basal layer and the columnar layer. Okay, this is the one. Normal appearing glands. In between this normal appearing glands, you are seeing the malignant glands, closely packed malignant glands. This is the normal appearing glands. You can see here also you can able to differentiate. This is the normal appearing glands. This is the basal layer. This is the columnar layer. This is the basal. This is the columnar. You can see this malignant. This is a secretion. This is secretion of the corpora amnesia. You can see a demonstrating small glands crowded in between larger benign glands. Larger benign glands, in between you are seeing this small glands. The higher magnification shows the enlarged nuclei here. This is for your enlargement of the nuclei. Prominent, if this is the prominent nucleoli. Prominent nucleoli. It's clear this one? Along with this, I will keep you this picture so that you can able to, you won't miss it. Yeah, prostatic carcinoma lesion also. Next we will go for female genital tract. In this female genital tract, this is the squamous epithelium. The lining epithelium of the cervix is squamous epithelium. What are the two parts of cervix? Cervix is over? Cervix lecture class is over?
No, not yet.
Not yet over? No. Okay. Okay. Cervix, it is having two layered epithelium. Okay. There are two parts. One is an ectocervix. It has two parts. One is an ectocervix, another one is endocervix. Then from the endocervix, the endometrium starts. Okay. It's an U-shaped uterus. Uterus. Then in the end, you will see cervix. In the cervix, this tumor, this layer, what you have kept here, this is the ectocervix. What you are seeing, squamous epithelium. If the patient has been infected by human papilloma virus number 6 and 11, okay, it causes and changes. Main first few changes are coilocytotic change. Coilocytotic change nothing but you can see here this epithelium which is close and adhesive. Adhesive, okay. Here you can able to see the difference here, which is very close and adherent. Like these cells are like bricks. If you construction a building like a bricks, which is close with the cement. Here very loose, and you can see some kind of an empty looking. Okay, this empty looking is due to the infection by the human papilloma virus number 6 and 11. Maybe initial stages it may cause this. Sometimes this patient may be land up with, these are the risk factors for squamous cell carcinoma, for cervical intraepithelial neoplasia grade 1, grade 2, grade 3 like that. Okay, this is the beginning stage. You got it now?
Yes.
Fine.
So doctor, this
Coilocytotic change. This coilocytotic change nothing but this arrow mark what I indicate.
but they are pre-malignant cells.
Yes. Now I am going to the cervix. This is the cervical os. From here it starts cervix here, then here uterus here. Okay. This is the cervical os. What you are saying is this is the cervical growth over here. Okay, which is protruding outside from the cervical area. The same thing, cut section. As I said, it's an cervix lined by stratified squamous epithelium. The tumor from the cervical is squamous cell carcinoma cervix. So this is the squamous cell carcinoma. This is the keratin pearl squamous cell carcinoma cervix. Keratin pearl squamous cell carcinoma cervix. It's clear? Okay. This same thing here. Epithelium, stratified squamous epithelium. Here the epithelium is breached because of the tumor. These are the tumor cells. These are all the tumor cells. Here also you can see low, deep tumor cells. Tumor, tumor, tumor. Next is chocolate cyst. What is chocolate cyst?
Endometrium.
Huh? Very good.
Part of the endometrium.
Okay.
And because of the hormones, cycles of the hormones.
Very good.
Become
Where you will see this chocolate cyst?
the ovaries.
In the ovaries. Presence of endometrial glands, endometrial stroma or hemosiderin laden macrophages apart from endometrium you are seeing anywhere. Okay, we will call it as endometriosis. Okay, you are seeing this one in ovary. As he said, all kind of cyclical changes it undergoes and it causes chocolate cyst. This is the ovary, cut section of the ovary. Next is this was I said you, this is the from here to here, this is the cervix. Here endometrium starts. From here to here ectocervix, from here to here endocervix. This ectocervix lined by stratified squamous epithelium, here lined by columnar epithelium, not totally lined by columnar epithelium. Okay, if the tumor is going to start from here, stratified squamous cell carcinoma cervix. If it is going to start from this area, it will be having columnar epithelium. So, what is the tumor? If it is going to start from here, it is squamous cell carcinoma. If it is going to start from here, adenocarcinoma. Okay, fine. This picture shows you a polyp, a pedunculated polyp. Clear? You didn't have polyps, right? Okay. Now it's an polyps. This is the polyps can occur anywhere in the genital tract. Either it can occur in the cervix, either it can occur in the uterus. This picture shows, this gross picture shows you a large elongated mass attached to the uterus, okay, like a peduncle, like a grapes which is attached to the stem. That area we will call it as peduncle, which is attachment. So that small kind of attachment called as peduncle. This one we will call it as pedunculated polyp. Uterine leiomyoma. Uterine leiomyoma, it is a benign tumor of uterus. This is the nodular pattern. These are all the benign tumor. This is from here to here, this is cervix. Here to here, this is the, if you close from here to here, it is cervix with uterus. I have done a cut section entirely and I have placed it above. From here, I have placed it above. You got it?
Yes.
It has leiomyoma, it can occur anywhere. If it's occurring here, we call it as mucosal here in the mucosa. If it is in between this, from mucosa to muscle, we will call it as intramural. If it is in the serosal, we will call it as serosal leiomyoma. 3 types, but there is no any kind of significance. It can occur anywhere in this part. Okay. So what is here? You have to, if you keep this picture, kindly mention as uterine leiomyoma. The same thing, microscopy. you will see this pattern. This pattern nothing but leiomyoma indicates it's a benign smooth muscle neoplasm of uterus. So if you see the microscopy, because of the smooth muscle neoplasm, the microscopy also it will show only neoplastic smooth muscles, which is benign. It's clear for you? Last verse, it's clear? See, this uterine leiomyoma, it's a benign tumor of muscle, of uterine muscle. Okay, uterine muscle, it is very smooth muscles. This is the pattern you will see in the uterine muscle. But the tumor which is arising from here, it is a benign tumor. It will have a same resemblance with the normal uterine muscle. Okay, but it's a tumor. Fine. This one. How we will describe here is the leiomyoma reveals the bundles of normal looking smooth muscle cells. Both the sides, if you see in microscopically, both the sides it will be tapering ends. Here also it will go taper, from here also it will go on taper. Okay, tapering ends will call this. But you don't need to remember those things. It's a smooth muscle cells. Next I will go for ovary. All these pictures are there from your Robbins book only. Okay. Ovary, in ovary if you consider there are many neoplasms are there. In that neoplasm, serous neoplasms are more common. Okay. But in Robbins book they have kept this mucinous, because mucinous is very easy to pick it up. Why? In the sense, this is the mucinous, this is the cystic areas what you are seeing here. This area shows, if you see in the laptop you can able to pick it. This is the mucinous area. It's a mucinous cystadenoma with a multicystic appearance and delicate septa. This is the delicate septa. In between this cyst you can see the delicate septa. Note the glistening mucin within the cyst. This is the glistening mucin within the cyst. And if you do the cut section you can see mucinous epithelium. Mucinous epithelium mostly you will see an columnar layered epithelium. Inside the lumen you will see mucin here. Here also you will see mucin. Everywhere you will see mucinous epithelium. Clear? But this is less common. Serous adenomas, serous carcinomas, serous cystadenoma is more common. Next is about dysgerminoma. Tariq, can you tell me something about dysgerminoma? You said something.
No, but this means a disturbance of the growth.
Okay.
Germinoma related to the germ cell layers.
Very good, very good. It's a germ cell tumor. Testis seminoma, the same kind of feature if you are seeing in ovary, we will call it as dysgerminoma. Okay, fine. Dysgerminoma, but here the gross picture it little differs. It will be pink, grey to pink in color. But here you can see this is the nucleoli and this well defined membrane here. This picture, see this is the lymphocytes, these are all the lymphocytes. These are all the lymphocytes. These are all the lymphocytes. This is the nucleus and the cytoplasmic membrane here. If you are not getting this dysgerminoma discussion in your lecture class, I will remove it. Okay. Last slides. What's time now? 40. Okay. Teratoma. What is teratoma? Testis. Teratoma. What is teratoma? Testis. Yourself?
Me?
Yes.
It's a tumor from the three origins, the mesoderm, the ectoderm.
Yes. Mostly what happens, till now we discussed the tumors, cervical carcinoma, okay, only from the ectoderm, it arises from the ectoderm. He showed me on a papillary carcinoma, it arises from endoderm, like that. Each and every tumors, GAT tumors, it arises from endoderm. Each and every tumors arises from only from the one germ cell layer. But only teratoma, it arises from all the three germ cell layers, ectoderm, endoderm, mesoderm. So you will see in the one tumor itself, you will see hair, tooth, sebaceous glands, papillary glands, brain tissue, thyroid tissue, respiratory epithelium, cartilage, bone, everything you will see in one tumor. We will call it as teratoma. This is the hair ball. These are the various thickening. This all thickening shows you various tissues of other glands. Okay, various tissues. What you are seeing is a keratinous squamous epithelium, cartilage, stromal tissue, cyst. Some cyst maybe cyst of ovary. here hair follicle, endothelium, epithelium, sorry. This is the primitive neuroectodermal tissue, nerve tissue, some cyst with the columnar epithelium. You can see all kind of sebaceous glands here. If you go for the hyper view, you can see some smooth muscle, sebaceous glands, a blood vessel, epidermis. This is the epidermis, keratin material. Further hyper, one more view for you. This is the respiratory epithelium. These are all the mucin producing glands. This may be from the salivary glands, okay, salivary tissue. I kept you few things, but many things are there, many features are there. Smooth muscle cells, thyroid tissue.
So we'll ask this, what's the diagnosis here? Or
I'll keep you this slide, I'll remove these points.
okay.
It's clear.
I'll keep you this slide along with this, okay. I'll just build this. Next we'll go for the breast. In breast we are going to discuss only about, in breast, last two slides. In breast we are going to discuss only about two tumors. One is a benign tumor, another is a malignant tumor. Coming to the benign tumor, one is fibroadenoma. It's a benign tumor of the breast. This is the breast tissue. You can see some kind of an white yellowish mass which is having a well defined, okay. You can able to see the border here, okay. This is the breast tissue. So rubbery, well circumscribed mass is clearly demarcated from the surrounding adipose tissue. If you see this in microscopically, you will have two patterns. This is the duct, this is also duct. Here what happens here in fibroadenoma, there will be abnormal proliferation of stromal tissue. And there is a huge proliferation of stromal tissue. It compresses the glands. This is the stromal tissue. These are all stromal tissue. This is stromal tissue. It compresses the ducts into surrounding, encircling the duct. We will call it as a pericanalicular pattern. If it is making the ducts into small slit like, we call it as intracanalicular pattern. These two patterns you will see. Okay. Again, fibroadenoma, it's a benign tumor. Again, in these pictures, again you will be reading in the breast lectures. Okay. This is very classical. Any doubts you have in this? Fine. Next we'll go for the carcinoma. This is the breast tissue. Again, it's a tumor in the breast which has been infiltrating towards the margin. See, the difference between these two is,
not well circumscribed.
huh?
This one is well circumscribed.
Very good. This is well circumscribed, but here it is having all kind of branches here and there. It is infiltrative. There is no differentiation. It is going here, it is coming here, it's going here again. Okay, this is an irregular firm white mass, contains chalky areas, elastotic stroma. This is a stroma that extends out into the surrounding yellow adipose tissue. If you see in microscopy, this is picture from your Robbins only, well differentiated carcinoma consists of tubules and cribriform glands. This is the tubules, this is the tubules, these are tubules. Okay, this is the cribriform pattern. This is small, this is the cribriform pattern. Tubules in the sense, if you the tumor cells which is forming like a small elongated structure, we will call it as tubules. Cribriform pattern like a nets, mosquito net. You have seen mosquito nets? Mosquito, for the prevention of the mosquito to enter into the house, we will have a mosquito nets. Same like, we will call it that as cribriform pattern, small round netted structure, right? The tumors, it will be presenting same like the tumor, small rounded. We will call it as cribriform pattern. This is one small. Okay, fine. This is the tumor cells. This is a hyperview. This is a hyperview of these cells. This is the stroma. How to differentiate here is, in fibroadenoma, the ducts are compressed into slit-like pattern, or else the ducts are encircled. Only here is, there is normal ducts, normal glands only, but due to the proliferation of stroma. But here, the cells which are undergoing changes. In malignancy, the cells undergo changes. So you are seeing these are all the pleomorphic cells. Again in detail, Dr. Mamluk, he will be taking class for you. Okay, no need to worry about this. This is the all tumor cells. This is the tumor cells, and this is the stroma here. This stroma is desmoplastic.
So
Desmoplasia, nothing but the this proliferation of the stromal tissue is called as desmoplasia. Increased production of stromal tissue. Oh, yeah.
the adenoma doesn't have the stromal tissue.
Which one?
The adenoma.
The normal which has minimal amount of stromal tissue. Minimal amount, not increased amount. Minimal. Invasive lobular carcinoma difference here is file. These are discohesive infiltrating tumor cells arranged in single file, in the sense if you see in government offices, all those files it is kept in order. Okay, the tumor cells which will be like an order, we will call it as file pattern. Okay, all the tumor cells. Any doubts you have in this? See, these are all the slides I have kept it, all classical slides I have put up for you. Almost 75% of slides from the Robbins book only. Okay, so if you study, you can able to pick it up. Any doubts you have in this? I have completed male genital system, penis. Then we have completed the testicular tumors. Okay, in that only I completed seminoma, yolk sac tumor, embryonal carcinoma. Okay, embryonal carcinoma, if you are, I think so, it will be very easy for you. Only dysgerminoma, it's not so much classical. Dysgerminoma of ovary. Okay. Any even any doubts? Clear? Okay, fine. Thank you. Anything? Thank you.
Mirror.